जाएगी तो लाइव हो गए हम लोग। ACCMBhopal.org। तुम लोग देखो ACCMBhopal.org जाके। आ गया? म्यूजिक आ रहा है? ठीक, तो बंद करते हैं अब यहाँ पर, नहीं तो कॉन्फ्लिक्ट होगा। मतलब वो देख पा रही है, चेक हो गया। Good afternoon. So today's presentation, though it's written modes of mechanical ventilation, I'll be taking first half of this presentation where I'll talk about basics, applied physiology and related things, so that you must understand it deeply and then apply this knowledge while using mechanical ventilator in your practice. As I said, I planned it for Slido, but because it's a PDF, I can't do that. So my first question to you is, what is the full form of CMV?
Mechanical ventilation.
Controlled mechanical ventilation. Anything else? No? In ACPC, that is assist control, pressure control mode, fixed volume delivery is guaranteed. Is it correct? No. SIMV mode is considered best for weaning the patient. No. In ACVC, that is assist control, volume control mode, only ventilator initiates the breath. No. In ACVC mode, only ventilator initiates the breath. No. CPAP is a spontaneous mode of ventilation. Yes. This is a case vignette of a 45-year-old previously healthy woman who presents to emergency with 3 days of fever and progressive dyspnea and is admitted to ICU for influenza complicated by severe hypoxemia. She is intubated and chest radiograph following intubation demonstrates an appropriately placed endotracheal tube with bilateral patchy opacities and interstitial markings throughout lung fields without effusions. Her bedside EF of 0.75, that is 75%. Volume control, tidal volume is 500, respiratory rate 14, FiO2 1, PEEP of 5. And ABG is showing pH of 7.3, PCO2 of 45, and PO2 of 80. Since this was prepared for Slido, so the options which were put were which of the following therapies has been best shown to improve the survival of patients such as this is. The options were related to lung protective ventilation, that is high PEEP, low tidal volume ventilation. The other options were just to confuse you. So this slide was prepared just to make you understand that mechanical ventilator acts as a part of a treatment in ARDS, where it is a part of a treatment. It is not supportive, rather it's a part of a treatment. It is a treatment in itself. That is the only condition where mechanical ventilator is to be considered as a part of treatment. Others, where we are using it as a supportive care. For example, when we are doing general anesthesia cases, then it's just the support. When we are post-electively ventilating, we are just supporting. In pneumonia, we are just supporting. In ARDS only, it's a part of treatment. So ventilator is a treatment for only ARDS, not for pneumonia, not for other conditions where we are using it. So the entire content of my slides are this. I'll not go to end of it. I'll just try to focus on first half of it. So what is a ventilator? A ventilator is a very simple machine. A machine has to have some input, it must process it, and then deliver the output. That's the simple definition of a machine. So ventilator is a simple machine where we give some input, it processes that, and then it delivers a output which is provided to patient. If I ask what's the definition of modes of ventilation, what do you mean by modes of ventilation? There are different modes. Then it is just a predetermined pattern of patient and ventilator interaction, that we have predetermined it when we are saying that I'm switching to pressure control mode, I'm switching to volume control mode. So once we are setting the mode, then those modes have something which is predetermined that you can't change. So if I say ventilator is a simple machine, it has some input what we provide through power and pneumatics, oxygen, air. Then we set something on the ventilator, including modes, PEEP, tidal volume or pressure, inspiratory time, and we set some limits. So this is what we set, a predetermined thing, and then it delivers. Once we have used the predetermined thing, it will deliver in certain fashion. All breaths are not equal, all modes are not equal, they are different in a way. How the flow will be delivered, how the ventilator will cycle to expiration, how it starts the breath. So to understand ventilator, we need to know three things, that is trigger, target, and cycling. A breath is once it starts, how it starts is the trigger. What's the criteria to start a breath? Then it reaches to certain target which we have set, and then it will be there until it cycles to expiration. So cycling is a word which means inspiration to expiration. Trigger is in starting of inspiration, and target is what we have set. So if we define a breath, a ventilatory breath, then you know that how, if you define a breath in certain fashion, it will be a different mode. If you define a breath in certain fashion, it will be entirely different mode. So once we say what is mode of ventilation, then we are saying if we choose different trigger, target, and cycling pattern, we are in different mode. Modes are determined by what we like, particularly in particular time. Like I may change volume control to pressure control, but there has to be some reason for that. If I do not have reason, simply tweaking from one mode to other mode is of no use. Actually, it may harm. So you need to know that modes are very important. And what are they? They are just a pattern of interaction between patient and ventilator, and what we have preset. Like we are not going to tinker with the how it is going to generate the flow. That will come to understand better when we are talking about modes of mechanical ventilation. So actually we know that objectives of mechanical ventilations are only three. One is safety, one is comfort, and other is, once we are putting someone on mechanical ventilator, the same point of time we must think how we are going to liberate him. So it is not that after one day of mechanical ventilation we start thinking that now we have intubated, ventilated, now how to extubate now plan. The plan of extubation is inclusive in the indication in itself. Meaning, if you have a patient whom you cannot treat, like end stage malignancy, you shouldn't intubate, because you know the other end is not there. So it is not just simply shifting time of death to few days later, meaning proper utilization of mechanical ventilator is a must. We must not offer it to all. We must think before we are doing it. If I intubate, it might be a dead end, and if it is a dead end, then I must consider it now and here only, and I must discuss with relatives and whosoever is the undertaker for as a authority for them. And we must discuss in detail that if such patient is intubated, the other end is closed. That means by applying science or the knowledge, we cannot extubate, but it has to be done simply as we are intubating. As I am intubating just for no reason, I'll extubate for no reason. Meaning, intubating, decision of intubation in itself consists of how we are going to extubate, how we are going to liberate the same patient from ventilator, right? So this we must keep in our mind. This is telling you the same thing, that ventilator is a simple machine, and we give some input in form of power. You apply power cord, switch it on, then you provide compressed gas through wall. Then we have a transformation of energy where we are applying these two energy, and then mechanically it is transformed to some other forms of energy. Then we have a control scheme where we apply variables control, phase control variables, as well as which mode you choose, and then it delivers according to the plan. So before you understand anything in respiratory mechanics is the must. Before you understand any bit of mechanical ventilator, you need to know what we say mechanics. When we say mechanics, what do you mean by that? That mechanics is has to have some force. That force must displace something, and the rate of change of displacement, you must know it. Like in physics, Newton's mechanic, where we have laws. So when we say we need to know mechanics of respiration, then we must talk in terms of forces, displacements, and rate of change of displacement. Or if you say forces and displacements are same, then acceleration and deceleration is the third, rate of change of velocity. So as we know, force is what? Force per unit area is pressure. And so if I say, and what is displacement is, it it is like how much diaphragm is pushed, how much piston is pushed. So it is like area, cross sectional area, and the displacement or the distance of the, if you have bellows in your machine, anesthesia workstation, so that is tubular thing. So you know how much is the displacement volume only after, if you have area of circle multiplied by the displacement, right? Similarly, rate of displacement is flow. How? Volume change per unit time is flow. So if I'm saying volume is area of displacement multiplied by height of the bellows moved, that is volume. So rate of change of displacement is flow, that is volume change per unit time. So what I have done is, to make you understand respiratory mechanics, I have used the basic physics and then transform into three variables. And those three variables are pressure, volume, and flow. Now, if you volume and flow are related, volume and flow are related. How?
So flow is dependent on the volume itself. So if the volume will change and we keep time is constant, then flow will automatically change.
It is simply by the last third formula. Flow is volume per unit time. So flow multiplied by time is volume. So if I say, uh, if I know volume, I can infer about flow if I know the inspiratory time. So in a way, volume constitutes flow and time. So flow is an integral part of volume when we think of ventilator, since volume and flow are related. So if flow is inside the volume, then you can say that there are only two control variables. One is volume, the other is pressure, right? Third would be flow, but flow is in itself is a constituent of volume. So that's why if we say if we have only two control variables, so this knowledge will help you when we discuss modes of mechanical ventilator. So when I say variables, when anyone say variable, it is pressure, volume, and flow. When we say parameters, respiratory parameters, by definition, I am talking about only two things: elastance and resistance. So this is just a definition part of it. When I say how is the respiratory mechanics, then you start thinking from parameters first. As you know, if you think, whosoever needs mechanical ventilation needs it for just two things: to resist the resistance posed by the airway and to resist the elastance posed by the alveoli. If something goes wrong with your respiratory system, either elastance or resistance goes up. There is nothing else. Meaning, if you have tachypnea, dyspnea, there are only two things happening: either the airway resistance has gone up or the elastance of the alveoli, it is collapsing because of ARDS. It is collapsing because of wetness, extravascular lung water. So whosoever needs ventilation needs it primarily to ventilator opposes these two forces. Then your work of breathing goes down. That's why ventilator decreases the work of breathing. Patient has a respiratory parameter which is against normal physiology. So his tachypneic, dyspneic, desaturating. Respiratory ventilators just counters those things, try to counter those things and take care of only those two things, resistance and elastance. So to cut short everything out of the plane of this respiratory mechanics, you need to know only this, that my patient needs ventilator, so it must have two, either of the two or the combination of the two. There is nothing else. So think in terms of elastance. Elastance is something that is again inverse of compliance. Compliance is this, inflation में जो ease of inflating, and elastance is opposite. It is
Collapse.
collapsing from outside inward force. So elastin goes up, you have ARDS or pulmonary edema. Resistance is in the tubular structure or airway. So resistance goes up with the either secretions in the tube or the luminal thickening of the bronchial asthma or spasm of the air. So ventilator counters only these two things. It's a simple machine. It does nothing more than that. So simplifying the airway and alveoli, the right side of this, as you could make out, this airway and alveoli, simplifying to make it understand. So what we must know is these two pressures. These two pressures are is pressure, airway is a airway pressure, right? And the entire is respiratory system pressure here to the alveoli, the difference. What is this? Have you ever seen this equation before? This is the only equation. By knowing it, you can understand what your ventilator capacities are, how it will match the patient's demand. So this is called as equation of motion. Simply understand, if this ventilator has two ports and then it delivers to trachea or endotracheal tube. So as I said, ventilator is doing only two types of work, either anti-resistive or anti-elastic, right? So what it does is, I'm applying energy from one side, so it will decrease the demand from the other side. So patient who is tachypneic, dyspneic, desaturating is because they have some Either elastic work has gone up or the resistive work have gone up or both. So this will apply a energy and try to counter those elastic and resistive work and makes patient comfortable. So the two sides of equation, if we think of pressure from ventilator and the need from the patient's end, so trans thoracic pressure is what?
And we have the pressure in that.
And trans pulmonary means complete atmospheric to alveoli difference, right? So if I apply some pressurized gas through ventilator, then it must counter two works, elastic and resistive work, and that is PE is pressure elastic work and pressure of resistive work. The counter to ventilator, that is in the respiratory mechanics and the parameters of a person. So once we apply ventilator and we are not relaxing the patient's muscle, then both are working, patient's muscle and patient's ventilator's pressure, and both are working to counter elastic and resistive work of breathing. So the third part, if you come down, so this is patient's muscle plus ventilator is working on one side. As I said, elastic pressure and resistive pressure, those are the against these, against ventilatory and muscular pressure. So if I transform this pressure in forms of elastance and resistance, then elastance multiplied by is pressure and resistance multiplied by
Flow.
flow is resistive pressure. Just putting the value for P, I have transformed this equation in this form. Up till now, clear? So I'm saying ventilator and muscles are on one side of the equation and resistance and elastance are on the other side of the equation. Both must be equal. So now imagine a scenario where you are ventilating a patient who is relaxed, meaning the muscles are not acting. It's entirely ventilator on the other side, countering the same pressures like when we are relaxed the patient, then the ventilator is working from one side, there is no muscle, and the equation would be something like this. The other scenario would be when we are like no ventilator. Patient is not put on ventilator, then the respiratory muscle of the same patients has to do some work to counter the resistance and elastance in the lung completely. So usually when patient comes to us in ICU, they are scenario 2. They're trying to make up. So the work of breathing is about 5-10 times above what they are normally using. So that they are exhausted. They are fatigued because of all the energy is being utilized just to counter these two forces. And once you apply a positive pressure, either by mask or endotracheal tube or tracheostomy, then you are helping your patients to reduce the work of breathing. You are doing nothing. You are just simply doing nothing. It's a energy what you are giving, and those energies are utilized, so the patient is not utilizing his or her own energy. Now he is comfortable, since he is getting all physiologically he needs oxygen, he needs, most of the cardiac output is now centered at respiratory muscles, so his kidneys, his liver, his brains are not getting enough, and hence organ dysfunction starts. If such patients remain at community or not getting the proper support, organ dysfunction starts, because once you are utilizing 20, 30, 40% of your cardiac output, so only 50 is going for other vital organs, your brain, kidney, liver, skin. That's why once patient comes you in organ dysfunction, you can understand that he or she must have suffered in last 24 to 48 hours, and that's the deficit of energy has caused this, because organs are not perfused well. Now you have lactates higher, now you have lower oxygen, now you have a dull drowsy patient, now you have a patient whose kidney functions are marginally borderline or switch to the abnormal side, and same with liver. So when you are intubating and mechanically ventilating, you are doing just work, your ventilator, and that work helps patients reduce their own muscles and all the energy deficit process what we have discussed. And hence, it is simply energy exchange or provision of energy and resting the muscles, what ventilator does to any tachypnic, dyspneic, desaturating patients. It is doing nothing else. Complexity. The same equation, expanding it to, as we have discussed, this side is ventilator, and consider the patient is relaxed. So the P muscle is gone. Elastic work and resistive work, as we have discussed. So if you are using a volume control mode, if your selection of mode is volume control, then you are actually controlling the right side of the equation. Volume is on the right side. Right? And once you are using pressure control ventilation, then you are actually on the left side of equation. I'll take this. So if you know this equation, then you must think in this term, like what control I need to have for this particular patient. For example, if you have a COPD patient, so COPD usually have airway and some parenchyma involved as well, but usually they have more of an airway disease, and hence the we have to counter most of the time resistive work of breathing, and where we know that if we do not guarantee volume in such patients, then the ventilation would be different, and hence CO2 will be varying very often. So if we need CO2 to wash out, then we must focus on volume, and hence that time we are mostly concentrating on volume control, right? And situation would be different if we have someone where the airways are okay, but you have pulmonary edema. So if airways are okay, the CO2 won't become a problem. Then problem may be related to flow, because if the inspiratory flow demand is more, in such cases flow demand is more, and if we are utilizing volume control, and if we know that volume control is flow,
Fixed.
fixed flow mode, and for example if the person needs 80 liter per minute and the volume control can deliver only up to 60 liter per minute, each breath there would be some deficit, and hence if you look at the loops, it's not what you are desiring. It would be with a notch on the inspiratory arm and suggesting you that he is flow deprived. So when a patient is flow deprived, has no involvement of airway, that patient needs flow independence. So the simplest way to address flow asynchrony is to switch to something where flow is variable. Flow becomes variable. So that mode is pressure control. So then patient may get a flow as per their required flow requirements. So it may vary with each breath. As the patient needs more, flow would be more. Patient needs less, flow would be less. So simplest tool to take care of flow deprivation is to switch to pressure control mode. So that's how these two modes are important. Consider it when you are ventilating a patient. Same patient in the morning might behave differently, in the evening might behave differently. So that's why you need to monitor. That's why you need to monitor your ventilator. You become the command. Many a times I have seen people using dual mode like PRVC. And once you are using dual mode, then it is just simply what you are doing is you are inducing asynchrony, because now you have dual limits in place of one limit, and you have a dual alarm. So I'm giving volume, what I have said, but patients might have worsened, because now for achieving that volume, it calculates the resistance and elastance and then increase the pressure to get the desired target of a volume what you have set. So it is like it will look at one breath it gives and then assess the resistance elastance, two breaths, and then it said, okay, for 500 ml tidal volume I need to give this much pressure to achieve this. So it will increase the pressure in itself and deliver to target. Okay, so now you are away from ventilator because now sister won't complaint, patient won't complain, alarm won't ring most of the time. And now when you say that I need to wean off, then you switch back to some simple control mode, then you see no, it's not getting enough. Now patient is again dyspneic. So what has happened is setting a dual mode. I'm going for 2 days leave, I may put it on and go, and will certain with certainty I'll come back and then have my patients, and then I can start tweaking. So it is harming a patient, not giving attention to the problem root cause, rather than just comforting myself that the numbers are okay. So dual mods are for, like, it's a comfort, like where you say nowadays many end stage malignancies are being put on mechanical ventilator, and your primary physician may ask you to extend, go as long as you can. So once you started with single mode, simple mode, then you switch to dual mode. So it will giving you 3 days, 4 days, 5 days, but it's not for treatment. It's just for extension. So those dual modes were made, look, it was a feedback from doctors to the respiratory, to the manufacturers, that we need something of this sort, if you can help us out, and they found the way. They come with a dual mode. And if you go in details of modes, and if you go in details of dual mode, how they do things, it's simple algorithm. And by doing that, they might achieve the targets, but they might not have helped the patient a bit, might have induced asynchrony, might have induced atrophy. So it's not good. So whosoever is using ventilators people have trialed several dual modes and even after advanced modes to see if it helps in particular subset of patients, and they could not find any mode which could help any particular subset of patients. So finally, it is just what I have said, it's for the comfort of physician who is using it, not for patient at all. Maybe it may help you prolong ventilation, but it may never help you in weaning off. I hope with this simple equation, I tried to make you understand respiratory mechanics about parameters, and modes of ventilation is something. If you know this equation of motion, if you know how it is actually helping. Why?
So as you said, we should know the root cause, whatever is the root cause for which we are providing medication to the patient. Knowing what is important because we have to know whether the patient needs volume to be controlled or pressure needs to be controlled. If we are not aware of these modes, then we may be creating asynchrony in the patient, or we may even worsen the patient. Also, the patient could become ventilator dependent, and weaning off will be difficult.
This is one of the reason, but one more important reason for this was you have innumerable, like, you don't know how many manufacturers are manufacturing mechanical ventilators, and with manufacturing they name their volume control differently, their pressure control differently. So they give it a proprietary name. I made a ventilator, I'll not say it volume control, I'll say it's something else. I'll name it differently. So the users, if they're asked to use 10 different types of ventilator for a single patient, would be confused with the nomenclature of the modes. So for that, if you have something basics or the core of breath, knowledge of how breaths are defined and how this ventilator generates this breath, how other ventilator generates this breath, then you know that, oh, you have to set only few things on that machine. So it becomes easier if you know that how breaths are possible, how many breaths can it be possibly deliver. If I know, then I know whatever is the name, tweaking few knobs, you'll understand, oh, this is this mode with this name. So knowing the modes is like a standardization of nomenclature, so that once you have other ventilator, you can simply use your brain and use the knobs and effectively deliver the same breath what you want. So you need to know it. And it's mandatory. It's mandatory in America to know the modes for respiratory therapists. They do have respiratory therapists in their system where who are just operating ventilators. They are not doctors, and for that they need to know it. It's a compulsion that you need to be certified with this particular course in which you are taught about modes. As you could see, the upper names are of the manufacturers and the lowers are, they have named it. So it means it is confusing. If you use Hamilton, you know these modes. If you know Drager, this mode, Covidion, the names are this. Mackay, names are this. And actually they are this. So the names are different. So it is standardizing the names, nomenclature, that you need to know the names. Things if you know them. As I have said, it's mandatory. American Association of Respiratory Care makes it mandatory to apply to practice all ventilation modes, whatever is available on their ventilators, be it non-invasive or invasive. So I think we must stop here. And uh, these you must be knowing it. So next class, I may move up from here to talk of modes of ventilation. So thank you very much.